Top Med Talk.
Hello and welcome to Top Med Talk. We're coming to you live from the Perioperative Medicine Special Interest Group meeting, which is being held in Melbourne, Australia. I'm Kate Leslie. I'm one of your hosts, and my other colleague here is Desiree Chappell. Hi, Desiree.
This is very special for me. This is my first time to Australia. And so that has been wonderful. Here in Melbourne, we've been spending the week. You've been a wonderful host, as has everyone with the meeting, and the conveners have been wonderful to support us to be here. So it's been fantastic.
Desiree's been enjoying the coffee and also the weather in Melbourne, which has varied between 15 degrees and 35 degrees since you arrived.
Yeah, actually it's very similar to Louisville, Kentucky, where I'm from. It's all over the shop in the spring and the fall. Yeah, it's nice to... I don't mind it too bad. The coffee is particularly good here.
So everyone who's listening, please come to Melbourne.
Yeah, come on down. And Top Med Talk down under, Kate.
Yes, this is a continuation of our efforts from Brisbane and also from Melbourne only a month ago when Mike Grocott and I went to the ERAS Plus conference. So it's been great. And we have another two fantastic guests. Today we've got Associate Professor Jai Darvall and Dr. Chuan-Whei Lee, both from the Royal Melbourne Hospital, who were just part of a terrific session about frailty and end-of-life care. So, Jake, do you want to tell us a little bit more about yourself?
Yeah, thanks. Thanks, Kate and Desiree, for the invitation. I'm an anaesthetist and intensive care specialist at the Royal Melbourne Hospital, and my interest certainly in the research space is frailty. So the frailty syndrome, what it means for perioperative practice and intensive care, how we might measure it, what we should do about it, how we can improve outcomes for these increasing numbers of patients with frailty and very vulnerable patients in those specialties.
And Chuan-Whei, tell us a bit about yourself.
Thanks, Kate. I am an anaesthetist and pain medicine specialist, also from the Royal Melbourne. My interests are in pain management of the older person and care of patients at the end of life who are having surgery, and really incorporating palliative care principles within the perioperative journey.
So in the session it was very interesting the way your two talks intersected on the issue of frailty. In particular, Jay, you talked about the intersection between the way the person was before their surgery and what the relative impact of their surgery and their preoperative condition was on their outcome. So do you want to tell us a bit about how you assess frailty preoperatively and then how it impacts the surgical journey?
Yeah, certainly. I think frailty really is quite a simple concept when you drill it down, and it's about vulnerability to stress. And we certainly see stress in the perioperative context. We're operating on patients and they might have come in emergently, they might have suffered trauma, might have sepsis, maybe it's elective surgery, and this all puts stress on the person. And depending on their level of frailty, they have increased vulnerability to that stress, and whether they can recover to their baseline or whether in fact they have functional decline and potentially even a really bad outcome through the perioperative journey is in a large part due to how they were living before they came into hospital. In answer to your question about how we measure it, there's lots of different frailty measurement scales. Some are more difficult to administer than others, but I think what's really exciting in the coming years in the era of electronic medical records is a lot of this measurement process can be automated, and there's much exciting work happening around the world in really automated frailty measurement, which helps us as perioperative clinicians from the very start.
So Desiree, you're the Chief of Clinical Quality for a large anaesthesia network in the US. Is there any systematic measurement or assessment of frailty in your network?
We have over 250 different facilities, and we have everything from small little independent practices that do absolutely no pre-op assessment until the day that the patient shows up, especially in our ambulatory surgery centers where theoretically we shouldn't be seeing frail patients, but I know that we do, all the way through to major centers that have a very robust preoperative clinic where they are doing frailty measurements and things. I don't feel that it is as integrated into our pre-op assessment as maybe in other countries. And I don't think that there is a standard for that at all across the board. So that's what I was actually going to ask the reverse. In Australia, is this something that is done for every patient that comes? So frailty is
not as yet. There's exciting work, I think, probably coming out of Canada, which are at the forefront of certainly frailty definition and measurement really came out of Canada as a world leader. There's a lot of electronic medical records, so-called electronic frailty indices, which are coming out of Daniel McIsaac's work and certainly Ken Rockwood's work in Nova Scotia. But it's pushing out. And one of the beauties of electronic medical records, once a tool is built in, it can be very rapidly pushed out and adopted in other healthcare services. So I think the next 5 to 10 years, we as perioperative clinicians are going to be talking the language of frailty much more routinely with our patients.
And do you have EMRs, electronic medical records, in all of your facilities?
Not in all of the hospitals in Australia, but they're increasingly penetrating many health services.
And I think there's a couple different major ones that you may see in each one. So it's not one standard.
No,
that's say. And that's the way it is for us too in the U.S. There's a large portion, probably over 50% now, that are on electronic medical records, but there's still a lot of smaller providers in hospital systems that do not. Just makes it very difficult.
So, Chuan-Whei, you described the trajectories that occur at the end of life, and having frailty and dementia puts you on, unfortunately, on a trajectory towards the end of life. Can you describe the trajectories that you mentioned in your talk and give us some more detail about that?
So there are 3 major trajectories at the end of life. There's the one for cancer, which is when a person is very high functioning and has rapid decline in the last 3 months before death. There's the organ failure trajectory, when a person has a declining baseline and then experiences very serious episodes within that baseline. They tend to have very erratic function in the year before their death. And then there's the frailty and dementia trajectory, and these patients have a very prolonged decline. They tend to be low to moderate functioning for the year before their death. And in fact, the frailty trajectory can last for many years before death, and it's very difficult to see transitions. And all 3 trajectories have a commonality, which is in the last 3 months before death, they all suffer a very serious decline in function, which is the same across all trajectories.
You also mentioned another trajectory, which is the sudden death trajectory. And you made some really interesting remarks about how the whole of medicine and nursing and allied health, in fact, are directed towards the sudden death trajectory. So someone comes in with a catastrophic problem and we all concentrate really hard on trying to fix it, when what we should possibly be recognizing is that the person is approaching death with or without all of our efforts. Can you tell us a bit more about what you said in your talk along those lines?
The sudden death trajectory is the basis for which most hospitals will deliver care and treatment. And this is the assumption that everyone that comes to the hospital is healthy and high functioning and independent, and something very unexpected has befallen them, and that's why they are ill. It doesn't take into account for the fact that there may be patients on different trajectories in the hospital setting. And in fact, only 15% of older people in the community will be on a sudden death trajectory in the year before their death, and the vast majority will be on an end-of-life trajectory. And the problem with that is that, as Kate has said, we manage patients very aggressively on a sudden death trajectory because we're trying to prevent the outcome of death. And so we'll treat them very aggressively until often within hours of death. And for patients who are already at the end of life on one of those other 3 trajectories, that may not be appropriate because they are transitioning naturally to the end of life and the terminal phase, which is the active dying phase.
They were very specific about that. Can you tell us the research about the surprise question, what that surprise question is, and So
this is a tool that can be used to identify patients who are at the end of life, not necessarily those within the last hours or days of death, but within their last months or years before death. It's a fairly simple tool. The palliative care physicians have designed it for us non-palliative care physicians, and it goes simply like this. Would I be surprised if the patient dies in the next 12 months? And if the answer is no, I would not be surprised. That patient is at the end of life. And in the context of surgery, we just add a small modifier. Even with surgery, would I be surprised if the patient dies in the next 12 months? The research on this is really interesting in the surgical population. There was one study done in emergency patients with emergency general surgeons, and they determined that if an emergency general surgeon said, no, I would not be surprised if this patient dies within the next 12 months, even with surgery, the odds ratio for 12 months mortality was 5-1, and it had an 81% sensitivity. It is actually a very good discriminator for predicting 12 months mortality, but that is not the goal of the question. The goal is simply to identify someone at the end of life and to start management with a palliative approach, so non-burdensome and symptomatic treatment.
So both of you are involved in the strategies to deal with these frail patients at the end of life, and you categorised them, I think, into clinics, into multidisciplinary team meetings, and into intraoperative and postoperative ward rounds. Jay, do you want to tell us about your experience with multidisciplinary team meetings?
Yeah, thanks, Kate. That's been a great initiative that's been set up at my hospital in the last few years. Been built fairly iteratively. We started with a fortnightly meeting. It's on Zoom. I think the pandemic has been good for a couple of things, but one thing is we're all very used to meeting virtually now. And what that enables is for a large number of different craft groups to come into the same virtual room to talk about usually 3 to 4 to 5, sometimes more patients on a weekly basis. And we invite the surgical team, who often they themselves have referred the patient, or us as anaesthetists have identified them from the usual pre-admission clinic, to join the meeting to talk through the patient and work out what the best course of action is for them. And that can involve a few different things. We might modify an operation. We might divert them from surgery entirely to a more symptom management pathway. Maybe that involves our pain medicine specialists. We might decide to kick the can down the road a little bit and get some more information. And so through that multidisciplinary meeting, we are linked in with some of our other perioperative structures like the POPS clinic, the perioperative care of the older surgical patient, where we might bring the patient in with the family usually as well, and in a more long form way meet with them. And in all of these areas, our geriatricians, our aged care colleagues are integral. They are really fantastic in the perioperative space. So that's been a fantastic initiative, I think, at our hospital. And I know that they're popping up in different health systems around the world, multidisciplinary meetings. It's time very well spent. It's often logistically quite challenging to get a whole lot of specialists in a room and spend upwards of an hour speaking about lots of patients, but it's one of the most cost-effective and time-effective strategies you can enact in the perioperative space.
Jay, if I may, whenever you talk about getting the band together and getting the team together, is that usually led by one clinician type? Is that driven by anesthesia, driven by the surgeon, or is there another body that takes a look at the cases that are coming through and then decides?
Yeah, that's a great question, Desiree. I think it depends on the health system and the individual hospitals. I was lucky enough to spend some time at Guy's and Thomas Hospital.
Yeah, I was just thinking, we've interviewed her for Top Man Talk.
She's incredible.
Yeah, she is.
Recent president-elect of the British Geriatric Society. And they started a POPS clinic, a multidisciplinary model at Guy's and Thomas there. It'd be over 20 years ago, I imagine. Very geriatrician-led. Yeah. In fact, anaesthetists don't feature in their preoperative workup much at all. It is a bit confronting for me when I saw their model of care, but it works amazingly well.
Yes.
So that's very much led by the aged care side of things. At my hospital, it's much more egalitarian, I think it's fair to say. We all share the leadership space, and the anaesthetic department runs our Tuesday meeting, and we prepare the slides, and we have a perioperative medicine fellow that is tasked with that job. But yeah, we all sort of work in together. So I don't think it needs to be led by any health specialty. Everyone just needs to play nice together.
Yeah, absolutely. See the value of everyone sitting around the table. I think that's the point.
The most difficult piece, though, is dealing with these patients once the decision to do the surgery has been made, and then putting in appropriate mechanisms afterwards to ensure that they're comfortable and treated appropriately. And Chuan-Whei, you told us some very interesting information about clinical momentum. Can you define that and then describe it like a typical scenario of someone who gets trapped in clinical momentum?
Clinical momentum is the phenomenon where there's an automatic cascade of increasingly invasive interventions which are offered to patients without really thought to alternative or benefit. And we see this in the hospital system. A patient may come in, they might be at the end of life, they might be severely frail, they may or may not be appropriate for surgery, but because we don't recognise them, we take them off to surgery. And they'll have a lot of interventions on the path to surgery, including blood tests, imaging, often a CT scan, radiation. There may be a complication because their tissues are more frail, and we'll try and fix that complication. And there may be a complication, anaesthesia, we'll try and fix that complication. And eventually there'll be so many complications they'll end up in the intensive care unit. which is another step in clinical momentum. And then finally, in ICU, there may be more interventions and more interventions. And the studies definitely show that if a person dies in hospital in the last 48 hours of life, the vast majority, up to 90% in ICU, receive active interventions throughout that 48-hour period. And that is a very good example of what clinical momentum is.
How do you de-escalate?
It's very difficult to expect a single clinician. We often think that if only one person stood up in that journey and said no, that would have been the end of this inappropriate treatment. It's very difficult to do that, and that's because the system encourages clinical momentum based on that sudden death trajectory we talked about before. And so what we need are system-embedded processes that allow diversion away from inappropriate treatment, that may be allowing surgery to take place and diverting away from other inappropriate treatments, such as the escalation of treatment to resuscitation, or it may be the escalation of treatment to the intensive care unit. And understanding why we're doing surgery is really helpful in that.
You presented a fascinating article about surgeons and clinical momentum, which got a laugh from the audience, but also had a really strong message. And it was about how the main thing that encourages surgeons to operate is the availability of an operating room. And we all know that surgeons love to operate. But then we went on to discuss how the main thing that might encourage you to agree to go ahead is the availability of an intensive care bed. Can you tell us a bit more about that study? It was from America and it was very interesting.
Yes, this is an excellent study that was published last year from a group that defined the term clinical momentum. And it's a study of 2,500 surgeons, and it was a survey. And they were given 2 vignettes. Both patients were at the end of life, both patients were in ICU, and both patients have a surgical illness that's not survivable with or without surgery. And as Kate has said, the most influential factor for the surgeon taking that patient to theatre was having an operating theatre available. The odds were 4-1 if an operating theatre was available. They also determined that other factors that could lead to clinical momentum was whether the intensivist agreed or didn't agree with the surgeon, the influence of the family on clinical momentum as well. But the main point to come out of that study was that it's the system that very much encourages us. And although this particular study looked at surgeons, I'm sure we could perform the same study in anaesthetists, as Kate has said. If there's an intensive care bed, what's the influence on that for us taking patients to theatre, even if we think it's a bad idea? And usually with ICU, they feel like they're the end of the road. And this is where all our strategies have come into place with perioperative medicine. We've spoken to the intensivist and said, if you feel like you're the one saying no, you could actually kick the can down to us at the perioperative MDM, if time allows. And we can, in a larger multidisciplinary and consensus context, talk about mitigating clinical momentum.
That takes me right back to, I feel like I'm back in the ICU working, because there were so many of these times as a critical care nurse that, and I've never heard that term clinical momentum, but as soon as you said, I'm like, that's the one, because you'd be taking care of a patient day after day and they're just continuing to deteriorate. And the conversation is, what can we do, or what are our options? When many of us are standing there going, you sure this is what we need to do? Or is there any way to stop this? And you try and have conversations with the family, but it's very tough. It's very tough to stop the momentum.
So, Jay, you're a practicing intensivist. How do you deal with that? And I was particularly interested in what Desiree said about the opinions of the highly skilled nursing staff in the unit who've had a lot to do with the family.
I mean, Desiree, things have not changed in ICU since you were practicing. In our session this morning, I spoke a little bit about this phenomenon of persisting critical illness, which there's various definitions, but probably the most harmonised one is where the reason for the patient coming to the ICU is no longer as important for their ultimate outcome or mortality prediction as who the patient was. So what their antecedent characteristics are, what their baseline living status was, and so on. And you would remember from ICUs, and it's becoming more common as patients get older and with increasing degrees of frailty, the patient that's been in the unit for 15 days, 20 days, 30 days. Sometimes you come on as the intensivist or the critical care nurse, and you have to wade back through the notes to find a reason why they came in the first place. That's increasingly common for me on the rounds. You ask the resident that might be the continuity of care and they've been there for a week, you know what was the original insult? What were the injuries from the trauma? Oh, I can't remember. Because now
It was a pneumonia or a UTI or something.
but now they've got the tracheostomy and they've developed the renal failure and the filter, and then they bled from that, and now they've gone back to theatre for the gastroscopy, and they've had this cascading clinical momentum that's supervened. And it can be very hard to remember the original insult. We know that these patients stay a long time. They occupy about a third of all ICU bed days, even though they're only about 5% of the total number of patients that come through. To answer your question, Kate, how much we rely on the ICU nursing opinion, a lot. I find that increasingly so in my ICU practice, because they're the ones often that have the most interaction with families at the bedside, and certainly they're the ones that spend the most time with the patients. And so it can be really useful for insights into, for example, a patient's mood or their level of function, how they're operating around the bed space, to really take all the opinions of the bedside nurse, allied health teams and so on when you're trying to work out how to progress a patient like that.
Yeah, so many times you're in the room giving care to the patient, but talking to the family as well. And so you learn so much about that patient. And that's where we have those honest conversations about what does the patient want? Because it's much different when you have an evolving conversation with a caregiver versus a surgeon or a doctor walking into the room and say, what are their wishes? And they really hadn't had time to digest what the information is that they just received. And so I feel like it is a wonderful partnership and collaboration if you can make that happen in an ICU setting or any other type of care setting to be able to make those decisions that I quite honestly hadn't really, of course, as a nurse, you think about these things like, oh, why do we do this? But now after the years in here, and it really harkens back to the plenary yesterday at the start of the Congress or the meeting from Ranjana Srivastava about the arrogance.
She recouched that as more paternalism.
That's right.
And whether doctors should offer patients lots of options or give them recommendations.
Yeah, and even then I thought paternalism still has a little bit of a negative connotation, but as she explained it further, it's exactly what you're saying, that we're able to have a conversation and offer the different options. You're not saying one is better than the other, perhaps, whatever's best for the patient, but you give them options and then you say, this is what the outcome is going to be, and lead them a little bit more. Because it's hard to make your own decision in those.
I think the best tool on that front that I've read about and I've incorporated a little bit over recent years in my practice is the best case, worst case tool, which Margaret Schwartz, if I'm not mistaken, out of Wisconsin, palliative care physician. And really it is exactly what you've just said. It's working with ideally a patient, but if they can't advocate for themselves, they're surrogates about, right, this operation or this clinical course of action, what is the best case scenario? What is the worst case scenario? But most importantly, where do we think we're going to end up on a continuum between those 2 points? And it might be that the best case scenario out of a laparotomy is survival and return to baseline function at home. The worst case is protracted hospital course, a pretty painful and undignified death. But really what the family and a patient wants out of you is, where do you think they're going to be on that front? And that might be more towards the negative end of that spectrum. So say that. And often that's all the family's looking for.
So it's been a fascinating conversation. I'd love to thank Chuan-Whei and Jai Darvall for their part in it. And I think we should end it on a positive note about how we all need to get on with living healthy lives that really set us up to deal with the last part of our life with joy and dignity, don't you think?
Absolutely.
Desiree?
I'm right there with you.
Thank you for listening to Top Med Talk. You can find this podcast on our website, on YouTube, where you should give us a big thumbs up.
And subscribe.
On all of our socials. We'd like to thank our sponsors, and we'd love you to come back and listen to all of our podcasts. There are thousands of great podcasts to enjoy. See you later, Desiree.
See you later, Kate.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube. And of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.